Welcome back to the Deep Dive. This is where we take some of the most complex, dense medical source material and really try to crack it open for you, the learner.
Right.
So you don't have to wade through it all alone. Today we're doing something pretty ambitious. We are performing a deep dive into a massive surgical resource, an atlas of head and neck surgery.
A big one.
A very big one. And the goal here is to pull out that core practical knowledge you need to operate safely, effectively, in what is, a very complex region. So let's unpack that mission.
Our goal today is really precision distillation. We're trying to move past the basic anatomy and focus just on the execution.
The how-tos.
Exactly. The absolute fundamental principles of diagnosis, surgical planning, and maybe most importantly, the critical safety checks that really underpin successful outcomes in the head and neck. We want to give you those nuggets that separate, proficient practice from real mastery. But what's crucial to remember, and we have to say this, is that while we're discussing these high-level procedures, the ultimate responsibility for diagnosis, for determining doses, and for selecting treatment for any individual patient, that remains solely with the practicing professional.
Of course. And we're covering a huge spectrum today. We'll start with the foundation, diagnostic endoscopy, and OR setup.
The essentials.
Then we'll dive into specialized laryngology, really focusing on reconstruction and voice restoration.
Mm-hmm.
And finally, we'll get into the advanced principles of oncologic dissection and some key reconstruction techniques. Okay, so let's start right where the journey begins, the first look. How do we properly examine the upper aerodigestive tract? What does that modern toolkit even look like?
Well, for most primary exams, we lean very heavily on flexible laryngoscopy.
Which is also called transnasal laryngoscopy.
Exactly, and it's so highly valued because it just provides the most comprehensive access. I mean, in a lot of patients, you can see not just the glottis, but also the subglottis and sometimes even the cervical trachea.
So it's not just about what it can see, it's how that helps with the diagnosis itself.
Precisely. Its biggest advantage over the older tools, like a simple mirror exam or even a rigid fiber optic telescope.
Which still have their place, I'm sure.
Well, they do for specific views. But the flexible scope allows for a functional examination. We can actually assess vocal fold mobility, swallowing mechanics, not just look at static structures.
And the technology itself is improved.
Massively.
Yeah.
Modern fiber optic tech lets us capture really high-quality video and photos. And this is just invaluable, not just for documentation, but for patient education and for objective follow-up. We can quantitatively compare how a lesion looks before and after therapy.
That sets us up perfectly for the operating room. So moving into a formal laryngoscopy procedure, safety is obviously paramount, especially protecting the teeth, the mucosa. What is the single most important technical detail that trainers stress about the fulcrum?
It's the surgical self-check. When you perform proper laryngoscopy, you have to apply anterior pressure against the base of the tongue. The critical rule is you never use the teeth or the alveolar ridge as a fulcrum.
That's the mistake.
That's the mistake. If you're pushing off the dental structure, you are absolutely risking injury.
And there's a great physical rule of thumb you mentioned about which muscles should be firing, right?
Yes. If you're doing it correctly, you should feel it in your triceps and your deltoid muscles.
Not the biceps.
If you feel your biceps engaging, that's a really strong sign that you're using an improper fulcrum technique. It's a quick way to check yourself and see if you're creating, unnecessary mechanical risk.
And for edentulous patients.
Right. So for them, while some people use saline-soaked gauze, the superior method is to place a strip of high-density foam-like, the kind from a neurosurgical headrest, put it inside a small plastic bag, and then position that between the laryngoscope and the alveolar ridge. It prevents mucosal trauma.
That's a great practical tip. Now let's talk logistics. The OR setup for these procedures can get cluttered. Lots of bulky equipment. What are the key setup points that ensure efficiency?
Well, efficiency starts with the surgeon's involvement. It should just be a habit for the surgeon to be present during endotracheal intubation.
Why is that?
Because observing the ease of exposure during intubation and seeing the blade size they use, it gives you an immediate prediction of how easy or difficult it'll be to place the larger operating laryngoscope later.
I see.
And logistically, anesthesia needs immediate IV access. And the patient shouldn't be turned more than 90 degrees away from the anesthetist. You have to maintain that line of sight.
And what about instruments? Standard trays just aren't enough.
No, not really. We highly recommend bringing in a dedicated surgical cart, one with multiple drawers. This gives you rapid, non-contaminated access to not only your expected equipment, but also any unexpected tools you might need mid-procedure.
Which leads right into airway contingency.
The most urgent priority. always.
Right, you mentioned these time-sensitive issues. We know for these procedures, the smallest possible endotracheal tube is best, usually a 5 or 6 French, just to maximize the view while still allowing ventilation. How does that impact the pre-op planning?
It creates a terrifying time limit. In an average adult, you only have about 3 minutes until they desaturate after respiration stops.
Yeah. 3 minutes.
Which means your contingency planning has to be flawless. If your backup is fiber optic intubation, that scope has to be in the room, tested, and ready to go before the patient even enters the OR.
And if it's a tracheotomy?
If the plan involves an emergency tracheotomy, that tray must be open, the correct blade loaded on the handle, and it has to be immediately accessible. You cannot afford to spend 30 seconds looking for something during that 3-minute countdown.
That emphasis on high-stakes preparedness really sets the stage for our next section, specialized laryngology. Let's shift to laryngotracheal reconstruction, or LTR, for acquired stenosis. This seems like a multi-step planning process based on really precise measurements.
Oh, absolutely. The length of the stenosis dictates so much of the plan, and we determine that length either by endoscopy or, if the airway is just too narrow for a scope, by a CT scan.
So the initial evaluation is key.
It has to be comprehensive. You're mapping every potential site of narrowing: anterior and posterior subglottis, the proximal trachea, the suprastomal area, and you're looking for any signs of tracheomalacia.
And that mapping then determines the stage. Can you walk us through the trade-offs between the two main staging options?
Certainly. So you have the single-stage LTR. That's where stenting is done immediately with an endotracheal tube, but that means an ICU stay, sedation, the whole thing.
But a faster
A
result.
faster result, yes. On the other hand, you have the two-stage LTR, which is a delayed procedure. We often use this when we're placing posterior grafts, which just take longer to heal properly than anterior ones. It involves a temporary tracheostomy, but it can be a less stressful, immediate post-op course for the patient.
And before any graft gets placed, there's a prerequisite diagnostic step, the MDLB.
Correct. The microscopic direct laryngoscopy and bronchoscopy, or MDLB. It's done before LTR for crucial information gathering. We need to confirm the degree of scarring, the exact extent of the involvement, and, critically, whether there's any evidence of aspiration.
Aspiration is a major red flag.
It can be an absolute or relative contraindication to this kind of major airway reconstruction.
Let's move to another area of precision, vocal fold medialization, or VFM, for restoring voice after paralysis. What's fascinating here is how the choice of material directly impacts the injection technique itself.
It's a great example of material science meeting surgery, really. For permanent VFM, we use established implants, PTFE, silastic adjustable metal shims, calcium hydroxylapatite.
But for temporary injections.
For temporary injections, the technique varies with the consistency of the agent. So for something like reconstituted collagen, you have to deliberately over-inject by a good amount because you get early volume loss from saline absorption.
Okay, that makes sense.
But if you're using a ready-to-use calcium hydroxylapatite paste, the source material advises using about 10% less over-injection. It just holds its volume better.
And where is the sweet spot for access and delivery? Is it consistent?
Access is consistently through the lower half of the thyroid cartilage, but the optimal medialization point, that shifts. It's typically posterior inferior in males, but often it's closer to the midpoint or even anterior in females.
Looking at long-term outcomes, you mentioned that just filling the space isn't always enough, especially in a complicated case.
That's right. The outcomes are almost universally poor when a patient has a fixed cricoarianoid joint compared to a vocal fold that's just passively mobile but paralyzed.
So what's the solution?
This is why arytenoid adduction procedures are so vital. They allow for a controlled repositioning of the vocal process's vertical height, and they correct these complex posture issues that a simple space-filling injection just can't reliably fix.
And just briefly, on laryngoceles, when do you choose the endoscope versus an open neck approach?
Good question. Internal laryngoceles, so cysts contained mostly within the larynx, can often be managed endoscopically. You excise the cyst and most of the false vocal cord.
But if it's external?
If it's external or a combined internal-external lesion, it's best handled with an open external approach. It really minimizes the risk of recurrence. And during that open surgery, the key safety check is the careful handling of the superior laryngeal nerve bundle right at the lateral aspect of the thyrohyoid membrane to prevent any alteration in swallowing.
We've covered reconstruction in voice. Now the challenge shifts entirely to tumor excision. Let's talk oncologic dissection and deep space surgery, starting with the principles of neck dissection. What dictates the philosophy behind the incision itself?
Incision design is so crucial, especially in patients who might have pre-existing radiation damage.
Huh.
A lot of surgeons prefer a horizontal transverse cervical incision, usually placed around the level of the hyoid.
And the reason for that is?
It gives better cosmesis, and critically, it avoids the high risk of a trifurcation wound breakdown, which is a huge concern in irradiated necks.
But there's a surgical trade-off there, isn't there?
There is, yes. The downside of a purely horizontal incision is you need much more extensive undermining to get full exposure.
Especially for certain areas.
Exactly, particularly for areas like level IA, which is important for clearing out lymph nodes.
Yeah, a very technical question on nerve monitoring during dissection. When you're dealing with motor nerves like the spinal accessory or marginal mandibular, what's the preferred level of muscle relaxation? It seems a bit counterintuitive to leave some movement.
It is a fine balance. Some surgeons will advocate for maintaining just minimal paralysis, maybe 1 or 2 twitches visible on the monitor.
And that's on purpose.
Oh, yeah. This is key because it allows for safe identification of those motor nerves using low-level cautery, but it prevents the strong muscle contractions that would interfere with the precision of the dissection or, lead to an accidental injury.
The rise of transoral robotic surgery, or TORS for oropharyngeal tumors, that's been a major paradigm shift for patients. Beyond just the surgical access, what are the biggest clinical benefits?
The benefits are substantial and they're long-lasting. TORS decreases the need for post-op radiation, or if radiation is still needed, it often significantly lowers the required dose.
And for the patient's recovery.
It's a game changer. TORS significantly lowers the hospital stay and dramatically reduces the long-term dependence on tracheostomy and gastrostomy tubes compared to the older open procedures.
And for the team.
For the team setting up the robot, the principle is to replicate the intuitive feel of open surgery. So the traction and countertraction instrument goes contralateral to the tumor, and the energy source is ipsilateral.
Let's discuss an incredibly complex dissection, carotid body tumor resection. This requires a completely different surgical mindset than a standard neck dissection.
Right.
How does that preparation change?
It's a radical change. I mean, the initial skin and platysma exposure might mimic a standard neck dissection, but the actual resection plane is completely distinct.
So what's the key?
Patience and meticulousness upfront. The time you spend early on getting wide exposure, identifying all the nerves at risk, the hypoglossal, vagus, superior laryngeal, and getting vascular control before you even start on the tumor, that's the time that saves the case.
And the technique.
You have to work adjacent to the artery, never on it, using specialized cautery that minimizes the risk of a rupture.
Finally, draining deep neck abscesses.
Ah.
When managing these, what's the safest external approach?
The external approach typically uses an incision that straddles the anterior border of the sternocleidomastoid muscle, placed high or low depending on where the abscess is.
And then?
Then you use blunt dissection, often just with a hemostat, until you encounter purulence. Once you see pus, finger dissection is often enough to break up any loculations. The tissues are friable, but the pus usually dictates the safest path.
And a quick note on pediatrics.
Yes. In children, a CT scan showing circumferential enhancement doesn't always guarantee an abscess versus just cellulitis. But lesions bigger than 2 centimeters or a toxic-appearing child, that generally warrants immediate surgical intervention. And it's crucial for follow-up to collect that purulence for aerobic and anaerobic culture. Mandatory.
Okay, now we move to some advanced technical applications. Let's talk about transoral laser microsurgery, TLM, for glottic cancer. How do surgeons make sure they've mapped the full extent of the tumor before they even start cutting?
Well, operative endoscopy is the gold standard, but it really requires angled visualization. Using 0, 30, and 70-degree angled telescopes lets the surgeon define the full extent of the tumor, checking for subglottic extension, anterior commissure involvement, all those hidden areas.
And the CO2 laser is the instrument of choice.
It is, yeah.
So this is where that precision rule comes in, about tissue integrity for the pathologist. How do you minimize charring to maximize how they can interpret the margins?
It all comes down to the power settings. For early-stage disease, you use the pulsed laser mode to minimize collateral thermal damage. And crucially, the surgeon has to use the minimal power setting that still achieves an adequate cut.
Because more power is bad here.
Higher power just causes unnecessary charring, and that really complicates the pathologist's job of interpreting the true margin clearance. And the quality control is intense. The specimen has to be meticulously labeled, oriented, and often the surgeon takes it directly to the frozen section lab themselves.
Wow.
And ideally, the laryngoscope is not moved until that entire visual field has been cleared by frozen section analysis.
Switching gears to voice rehabilitation after a total laryngectomy, tracheoesophageal puncture, or TEP-A. There seems to be a trade-off when choosing between primary TEP, done at the time of the laryngectomy, versus a secondary delayed TEP.
There is. Primary TEP offers the major benefit of a faster time to speech.
But there's a downside.
Yes, patients may initially have more difficulty managing the stoma because of immediate post-op pain and edema. Secondary TEP, on the other hand, offers a much smoother transition to voice because the stoma and the surrounding tissues are already stable and well-healed before the puncture is ever made.
The ability to do secondary TEP in the office with local anesthesia is a newer advancement. What piece of pre-procedure data is essential, especially for patients with a complex reconstruction?
This is where transnasal esophagoscopy, or TNE, is so beneficial, allowing for these in-office procedures. But pre-procedure imaging, like a CT or a modified barium swallow, is highly recommended,
Especially with a free flap.
especially if the patient had a free flap reconstruction. We absolutely have to evaluate the position of the neopharynx lumen relative to the posterior tracheal wall. Getting that spatial relationship right just drastically increases the success rate of placing the TT.
Okay, finally, let's touch on local flaps and grafts for reconstruction. When you're rotating a pectoralis major flap, what is the single biggest technical risk for the viability of that flap?
The flap gets rotated over the clavicle through a subcutaneous or subplatysmal tunnel. The critical point is making sure that tunnel is adequately large.
Not too tight.
If the tunnel is too tight, it can compress the vascular pedicle, and that will lead to compromise and potential failure of the entire flap.
And for split thickness, skin grafts, often used for coverage on defects like on the tongue, how do we maximize the likelihood of a successful take?
Reliability there hinges on preventing fluid buildup. The graft must be sutured loosely and then pie-crusted with small incisions, or meshed.
To let fluid out.
Exactly. It ensures that fluid can escape, which prevents a hematoma from forming and causing the graft to fail from lack of adherence. And finally, splinting that STSG for at least 5 days is absolutely essential to maximize the percentage of graft take.
So what does this all really mean for you, the advanced learner? I mean, whether you're performing delicate microlaryngeal surgery or a deep oncologic dissection, this entire deep dive, it just confirms one core principle.
And that is success relies entirely on meticulous preoperative planning, especially using high-resolution imaging to map complex anatomy, and combining that with step-by-step technical precision during the execution. The complexity of the head and neck just demands that every single safety measure is a non-negotiable step.
That is a phenomenal synthesis of some incredibly dense, high-yield material. And to make sure these critical safety and procedural principles really stick, we want to give you a short exercise to solidify the most time-sensitive steps we talked about. So imagine this scenario. A patient presents for a complex laryngoscopy procedure under general anesthesia. Before the case even begins, list 3 essential checks you must make regarding 1, the airway, 2, dental protection, and 3, the operating room setup to ensure safety and efficiency. And you can only draw from the critical principles we covered in this deep dive.
Yeah, think about what you need to ensure is physically ready in the room versus what you just expect to be available. What's the thing that prevents an emergency from turning into a disaster?
We'll leave you to consider those 3 essential checks. Thanks for joining us for the deep dive.
We'll see you next time.